Dengue is characterized by fever of sudden onset, headache, retrobulbar pain, conjunctival infection, pain in the back and joints. Pain in the back and joints are severe, like those of breaking of bone. That's why it is also known as break bone fever, lymphadenopathy, and maculopapular rash. So far, 5 serotypes of dengue has been discovered. Mode of transmission through Aedes aegypti mosquito. Clinically, we can see two types of dengue: classical dengue fever and dengue hemorrhagic fever and dengue shock syndrome. Classical dengue fever is benign and very rarely it leads to fatal, that means the death of the person. It affects older children and adults. Symptoms include fever and headache, pain in muscles and bones. Whereas dengue hemorrhagic fever is a severe type of dengue which affects children of 5 to 10 years of age group. Symptoms include hemorrhagic manifestations or with shock, thrombocytopenia. Thrombocytopenia means decrease in platelets. Decrease in platelets leads to leaking of blood, that means hemorrhage, and hemorrhage will cause hypovolemia leading to shock. This is the whole thing which can be seen in dengue hemorrhagic fever and dengue shock syndrome. Dengue hemorrhagic fever. It appears to be hyperimmune response, that is because of reinfection with a different serotype of dengue virus. Antibody formed against the first virus reacts with the second serotype virus, forming immune complexes. For example, if the person is affected with DEN1 serotype of dengue, and the person later affected with DEN3, then the antibodies which are formed against DEN1 will react with DEN3, leading to hyperimmune responses. Laboratory diagnosis. For laboratory diagnosis, we use specimens. Specimens are nothing but samples. For antigen and antibody detection, we use serum of the person. For isolation of virus and for PCR, we use serum, plasma, whole blood, autopsy tissues, mosquitoes collected in nature. Hematological diagnosis. Thrombocytopenia and hemoconcentration. Microbial diagnosis. Detection of antibody, detection of NS1 antigen, genotyping, isolation of virus and PCR will come under microbial diagnosis. NS1 antigen is present in dengue surface. Detection of antibody. We detect IgM and IgG antibodies, which can be detected by using ELISA. IgM antibody appears 5 days after onset of symptoms and persists for 1 to 3 months. IgG antibody appears later than IgM antibodies. First, we detect IgM antibodies using ELISA, that we call it as MAC ELISA. IgG antibody detection at an interval of 10 days or more is confirmatory test. Detection of NS1 antigen. We use immunochromatographic test for detection of NS1 antigen. NS1 antigen can be detected on the first day of fever before antibodies appear. If positive for NS1 antigen by ICT, it must be confirmed by ELISA. Likewise, we detected for antibody. First, we do for IgM antibody detection by using ELISA, and then we confirm it by IgG antibody detection by using ELISA. Here we use ICT for detection of NS1 antigen, and we confirm it by using ELISA. Isolation of virus. The virus can be isolated by inoculating clinical specimen into mosquito cell lines. Further identification can be done by using fluorescent antibody test. Polymerase chain reaction. Viral RNA can be detected in blood of the person by RT-PCR. RT-PCR means real-time reverse transcriptase polymerase chain reaction. Genotyping. Molecular typing can be done. A total of 18 genotypes has been discovered till now. Prophylaxis. Control measures include elimination of mosquitoes. Elimination of mosquitoes. We eliminate larval forms of the mosquitoes by spraying kerosene on the stagnant water bodies in our communities. And for we mainly use vaccine for prevention. Vaccine. The vaccine is called as chimeric yellow fever dengue tetravalent dengue vaccine, CYD-TDV. It's a combined vaccine for both yellow fever and dengue. 3 doses are given subcutaneously at 6 months of interval. Treatment. There is no specific treatment for dengue. For example, if the person is affected with fever, we give paracetamol. If the fluid and electrolyte imbalance is present, we go for fluid and electrolyte replacement. And there is decrease in platelet thrombocytopenia, then for 10,000 or less, we do for platelet infusion, and DSS is treated with blood transfusion and management of shock. So here, if the patient platelet count is less than 10,000 or less, below 10,000, then only we will go for platelet infusion.